Hello, everybody. Good morning or good afternoon, depending on when you are watching this presentation. But my name is Tara Thompson. I am one of the pharmacists and the VP of Clinical Services here at Innovation Compounding Pharmacy. And today I wanted to go a little bit over hormone restoration therapy and some of the possibilities that you have for your patients in the compounding realm. And even outside the compounding realm, we'll go over a couple things there as well. So let's go ahead and get started. I love to start off all of my presentations with this slide. I think it is so funny how everything comes full circle if you wait long enough. But if you think about a short history of medicine, you see here that in 2000 BC, people were saying, here, eat this root. This is what is going to cure or fix your ailment. About 1000 AD, they would say that root is heathen, say this prayer. In 1850 AD, that prayer is superstition. Here, drink this potion. 1940 AD, that potion is snake oil. Take this pill. The introduction of prescription drugs. Well, long before that, but when they started getting popular. 1985 AD, that pill is artificial. Take this antibiotic. And 2000 AD, or kind of in the particular century that we are in, that antibiotic is ineffective. Here, eat this root. So comes full circle back to the root, looking back towards more natural, holistic options, things that are more in tune with the body. We're looking for root causes these days and trying to fix the problem at the source versus using a Band-Aid to correct any type of symptoms or conditions that a patient might have. So anyways, just something fun to start your day off with. Moving right along. The agenda for today, we are going to talk a little bit about innovation compounding just because that is the particular pharmacy that I'm employed with, and which is also my disclaimer, but a little bit about us. But most importantly, wanted to get into more of what compounding is in general, how it can benefit your patients, what kind of patient populations we're looking at for compounding, also just some of the history of compounding. And then the things that you may be most interested in is hormone restoration therapy, kind of some of the overview of that, as well as getting into the nitty-gritty of the different hormones. So today we're going to go over the estrogens, progesterone, testosterone, and shortly over DHEA and pregnenolone. There is a lot of information that we'll cover today, so hopefully you will find something new that you do not know before. If you're new to hormones, or if you are just learning, we have great information that can increase the way that you practice and increase your patient outcomes and quality of life. However, if you've been doing hormone replacement therapy or hormone restoration therapy for a long time, also some information in here to help refresh those things that we forget, those little details, and it's always nice to have a refresher, right? At the very end, I know we don't talk a whole lot about female sexual dysfunction and pelvic health, but that is something, or a huge patient population that we see here at Innovation in our women's health line of products, as well as our patient population coming from some of our docs. So I'll just barely touch one slide on that, just to kind of let you know what's out there and what you can do about it. So for your information on that. A little bit about Innovation. We are a PCAB accredited pharmacy. We've been around for almost 13 years now. We do sterile and non-sterile compounding. So we believe in wellness. We believe in root cause. We believe in trying to fix the problem at the source, like we talked a little bit about earlier. We do only do sterile and non-sterile compounding services, so we do not have any retail type drugs or medications. I think one of the benefits of that is that we focus solely on compounding. We know the ins and outs of compounding, both sterile and non-sterile, following USP 795, 797, and 800 guidelines. We are truly the healthcare experts and professionals when it comes to compounding pharmacy. So also here to help you with any questions or give you the answers that you need for your patients. If you have a particular patient case you'd like to discuss with us, or you just need more information, clinical help, marketing support, protocol support, even setting up new types of offerings in your particular practice, Innovation can actually help with all of that. So feel free to give us a call. I will have our information at the end. We are licensed in 46 states, so we can ship into 46 states. I think one of the big myths around pharmacy and compounding in general is that the providers believe that the pharmacy has to be in their state in order for their patients to benefit from using its services, but that's not the case. Actually, you can use a compounding pharmacy anywhere in the nation as long as they're licensed to ship into your state as a pharmacy, then your patients can use their services. So we are licensed in 46 states, and our website shows the ones that we are and the ones that we are working on to get. So hopefully by the end of 2020, we will be licensed in all 50 states and DC. We are currently licensed in DC. So compounding at a glance, it is a 5,000-year-old profession. So it is one of the earliest and oldest forms of pharmacy. This is going back to taking active drug off the shelf and mixing it into the different strengths and concentrations that your patient needs. In 1940, it was estimated that 50% of all prescriptions were compounds. So they did a lot of still the apothecary style mixing. Today, only 3% of prescriptions prescribed are compounded. Seems like a very small amount, but if you think about the billions of prescriptions that are prescribed annually and then just on a daily basis, you can kind of get a little better grasp on how much drugs are actually being pushed around out there. Still, regardless of the 3% compounding, still a huge market, definitely in women's health, IV nutrition, weight loss, allergy, even animal health. Animal compounding is a very large segment of the market. So compounding pharmacy is just like regular pharmacy. We are regulated by the state boards of pharmacy. Depending on the states that you're licensed in, we are regulated by every state board that we are licensed in. So 46 state boards of pharmacy are calling us and getting information from us and inspecting us. So it is a very large endeavor. We're regulated by the DEA in each state and federally, and then the accreditation boards. So we are a PCAB accredited pharmacy, meaning that we undergo rigorous inspections every 3 years from PCAB, which is a joint of ACHC that does specifically the compounding pharmacy portion of the accreditation to make sure that your quality and standards are to the highest regard and you are doing everything to make the best compounded product out there to protect patient and employee health. So thinking outside the box is what I like to say about compounding. It is definitely one of those professions that you are thinking outside of the box. You're thinking, how am I going to get this drug into that patient and they're allergic to this and they can't take things orally and they need help. So you're thinking about different ways to manipulate that drug in order for it to get to the patient. So you definitely, as a compounding pharmacist, have to think that way. As a provider, you may have a patient who is unable to take certain medications because of the excipients, preservatives, allergies, sensitivities, gluten, lactose, that type of thing. Those would be perfect candidates for a compounded prescription because we can actually make most every drug in whatever concentrations and whatever fillers and excipients that we need to in order for the patient to get it. Manipulating the dosage form is huge. So we have several patients, including children, animals, geriatric population that cannot swallow. We have to put their particular medication into a topical form or a vaginal or rectal form. So definitely a huge market and patient population there that needs that specific help. And compounding in general is just a customized, individualized medicine that is tailored to a patient's specific need, kind of what we talked about a second ago. We work directly with providers, including physicians, advanced practice providers, mid-level practitioners, physical and sex therapists, counselors, PT therapists, and other clinicians to create customized medication solutions for their patients whose healthcare needs cannot be met by manufactured medication. So, and also medications that are manufactured that may be on back order or shortage, compounding can also play a role there. So just quickly, how would you choose a compounding pharmacy? You definitely want to find one that is licensed in your state, that has a pharmacist or team of pharmacists who have the knowledge that you need to help your practice or your particular patient population, and your access to the pharmacist as well. You want to be able to talk to them on the phone, call them, text them, email them, and them get back to you with the clinical information or answers to your questions. You want to choose a pharmacy who has strict adherence to the guidelines, including 795, 797, and 800, depending on what type of compounding they do. If they do all 3 types of compounding, then they have to adhere to all 3. You want to make sure that they have diversity of their portfolio to your practice needs. A myth is that a compounding pharmacy can do anything, and yes, they can do a lot, but there are specific pharmacies who specialize in different things. There are compounding pharmacies who do only animal health or veterinary medicine. There are some compounding pharmacies who only do geriatric or pediatric medicine, and then there's some pharmacies who kind of do a little bit of everything, and just make sure that your pharmacy is able to tailor to your needs. They may know another pharmacy that has those particular chemicals or drugs that you need, and can help you, guide you in that direction. You also want to make sure their pricing is competitive and fair for your patient, and also that they have methods of providing patient care to your patient, and your patient's able to access the pharmacist or pharmacy team in order to get their prescriptions. You want to make sure that they have a good reputation in the community and nationally, that they are a reputable source. The compounding ability and dosage form assortment, it kind of goes back to diversity of their portfolio, just making sure that they are able to compound exactly what you need. Some pharmacies may have different equipment than others. Some pharmacies may not do sterile compounding and you need an injectable drug, so you would have to find a particular pharmacy that worked best for you. And then most importantly, accreditation and inspection. You should always feel free to ask the pharmacist about their inspection reports, if they're accredited, whether or not they have the testing and requirements and C of A's and everything you should ask and have access to, so that you can make sure you're choosing the correct pharmacy for your patients and your patients are getting the best quality product. So I'm going to skip over a little bit of this. I kind of think we talked about it earlier, but if you have a patient who has sensitivities to medication, maybe they get a bad side effect from something like GI upset, if they require flavoring, if you need to adjust their profile up and down and are unable to do that with retail meds, that is where compounding would come in for you. Or if you have a patient who just prefers compounding, or there's something that is not made in the retail setting that you need for your patient, specifically the hormones, what we'll be talking about today, then you can find that at a compounding. Just quickly on the drawbacks, it's typically not covered on insurance. So these drugs are usually made and sold to the patient on a cash-only basis. So a patient would just pay the average $45 to $65 price or something like that. They should never have to pay a very, very large sum out of pocket, depending on what the drug is. If it is a sterile drug, that is a specialty drug, yes, sometimes the pricing can get high, but your patient should never be gouged for their particular medication. You want to make sure that the pharmacy you're working with is competitive with the market and also making it affordable on patients. So for instance, giving them discounts on large quantities, offering free shipping options, and that kind of thing. Compounding is not FDA approved. There are no clinical trials. There actually are lots of clinical trials out there, but for these particular drugs, they are not under patent. They are not made by a drug manufacturer, so they are not FDA approved. And there is typically sometimes a general lack of understanding regarding what compounding even is. I know even we get pharmacy students that rotate through our site and they still are confused on what compounding really does and really can offer, and they're actually going to be pharmacists. So sometimes it's just a matter of education. This is just a slide. You can check it out on your particular copies, but one of your patients who may be a candidate for a compounded formulation may need a certain strength or dose requirement that's not available. Maybe first-line treatment options have failed. They have a sensitivity or allergy to something. They preferentially desire a unique dosage form. So for instance, they might not want a oral capsule. Maybe they want a sublingual troche, something that dissolves under the tongue or in the buccal space. compounding can show up to the plate for those particular issues. So let's get a little bit into the bioidentical hormones. I know that most of you probably already prescribe or are familiar with these, but this is just a great overview if it's been a while or it's always good to hear. Bioidentical, we like to think about it as replacement. So these hormones are actually identical to the chemical structure of the hormone in the body. So when I say estradiol, I mean estradiol that the body produces. Our hormones here at Innovation are derived from the wild yam, but they can also be from soy sources. Synthetic hormones are actually substitutions. They're not the same as a replacement. They are synthetically made. So for instance, some of these being conjugated equine estrogens, and then the progestins as well. So you can see the little graph here at the bottom that I did. These chemical structures, I mean, the progesterone, the bioidentical structure is on the left. You can see that that's exactly what progesterone looks like. You can see the cholesterol backbone nucleus there. And then medroxyprogesterone acetate, which is actually a synthetic progestin, you can see the side chains coming off there, the methyl groups and that type of thing. So definitely a different structure than, and then also another methyl group down here at the bottom position. So definitely a different structure, looks similar, but definitely not putting into your body exactly what your body mates on its own. Also, just a side note, my presentation is very pink. I do apologize. That's the color of our women's health line here at Innovation. So it just kind of happened that way. But hormones, hormone replacement therapy isn't just for women. It can also be for men. We have men, hypogonadic men, or ones who are just needing DHEA pregnenolone replacement. We work with LGBT and transgender population who is with some of those patients who are in that type of transition. So definitely not just for females, so not biased toward the color. It just sort of popped up that way when we were making the presentation. So just another example of bioidentical versus synthetic. Bioidentical estrogens are on the top. You can see there E1, E2, and E3, whereas the bottom half of this particular picture are some of the synthetic or the estrogens derived from horses, for instance, and the structures just being, there are certainly some differences between the structures on the ones on the bottom. So we like to have patients replacing in their body exactly what their body may be lacking due to menopause, perimenopause, and that type of theme, that type of condition, versus putting synthetic. This is just some of the instances of, or controversies, I guess, that are out there regarding hormone replacement therapy. We've all heard of the WHI. I know there was a great presentation on debunking the WHI and the studies that have come out since the WHI kind of put a bad name towards bioidentical hormone replacement therapy. But as we have seen, that study was pretty flawed. It was using some synthetics in there and then making some claims that have since been changed or debunked. So you can read a little bit about that here. Some of the symptoms that we just hear here at the pharmacy, I have hot flashes, night sweats, vaginal dryness. I mean, you guys hear this all the time, especially if you're seeing your women patients. For men, it's erectile dysfunction or, muscle atrophy, or they're gaining weight, and that type of thing. Those can all lead to, or those can all be symptoms of hormone imbalance. So very important condition to get treated and to get the patient feeling better and increasing quality of life and patient outcomes. This is just a statement from NAMS. They do think that hormone replacement therapy is the most effective treatment for menopausal symptoms. You do have to be careful: blood clots, heart disease, stroke, breast cancer. But generally, women below the age of 60 and those who have been out of menopause for less than 10 years can greatly benefit from hormone replacement therapy. They also talk about the transdermal route being the preferred route. And just some stats on HRT. By the year 2025, the number of menopausal women is expected to rise to 1.1 billion women worldwide. So you can expect one of those 1.1 billion to walk through your door, um, or definitely more than that, hopefully. But so surely a very prevalent condition. You can see these baby boomers and this next generation coming up, transitioning into menopause. Vasomotor symptoms persist for an average of about 7.4 years, and then for some women, more than a decade. So, and then of course, any age group can go through menopause at different times in their lives, whether it be natural menopause or surgical menopause. We like to say age 60 to 65 is your sweet spot, but I've seen as early as 30, I've seen as old as 7. I mean, there's just a huge range of when a woman can actually develop into menopause, and everybody's body is different, so it's hard to say exactly that. The smaller the range, the more inaccurate, I believe. So I like to widen that range and say I'm thinking more of 50 to 70 years old, but you know, this is what they found in the studies. So just some interesting facts there, just to kind of get your mind wrapped around why we are doing this in the first place, and how many people it could actually benefit. For most, according to this particular study here, the benefit outweighs the risk for most healthy symptomatic women who are younger than 60 or within 10 years of their final period. So for those particular patients, the benefit does outweigh the risk. So just something to keep in mind. Some of the goals of HRT are to alleviate the symptoms. That's always our first and foremost. We want to get these women feeling better, restoring the protective benefits that were originally provided when they did have naturally occurring hormones being produced from the ovaries and peripherally. There are protective benefits to the heart, to the skin, to the bones, and we want to bring some of that back. And then reestablish their hormone balance. Hormones are all about balance. They go in balance with the thyroid and the adrenal glands, and just getting all that corrected in a woman can actually solve a wide array of problems that they may be seeing as well. So like even just insomnia. I mean, most times we are able to fix that with hormones. I've had so many patients come to me with insomnia issues, and I'm like, let's get a hormone panel, because I feel like we don't need to go directly to sleep medications on this particular one. I feel like this is a hormone issue, and sure enough, get those hormones in balance, and they are sleeping good again, for the most part. So this is just a depiction of the steroid hormone cascade. I love to show this as a teaching point, because you can see where the downstream effects are. We'll talk about most of these hormones today, try to go into as much depth as possible, but for the most part, you can see that they all kind of intertwine. They're all part of that steroid hormone cascade. Blocking things in certain ways or replacing things in certain ways can have a downstream or upstream effect on the other hormones. So it's just good to see. So let's get right into the estrogens. There are 3 main estrogens that we like to think about and talk about in the woman's body: estrone, estradiol, and estriol. Estrone is going to be your strongest hormone. So it's your hormone that is primarily produced after menopause, and it's about 10 to 20% of your circulating estrogens. Estradiol, or E2, di being the DI in the word, is why sometimes it's referred to as E2. It is about 10 to 30% of your circulating estrogens. This helps in hot flashes, increases in serotonin, and increases in HDLs, and helps your lipid panel. Estriol, or the tri in the word estriol, is sometimes why it's referred to as E3. It's about 60 to 80% of the circulating estrogen, and actually has a possibility of being protective against breast cancer. We have a really amazing article all about estriol. If you're interested in it, let me know, email me, and I will send it to you. It is fantastic. It's really a wonderful estrogen. Helps maintain pregnancy, helps benefit the vaginal lining. it actually blocks out estrone on the receptor sites on the breast. So it's actually, that's how they're, the mechanism of action for that against breast cancer. So that's the 3 estrogens that we're going to talk about. And you probably know many of the benefits of the estrogens at this point, but has a lot to do with being in sync or in balance with the progesterones. You want to make sure that estrogen and progesterone are always in balance to help with the menopausal vasomotor symptoms, but also estrogens are help in terms of the vaginal thinning and dryness, especially postmenopausal women who aren't producing that estrogen anymore for themselves experience a lot of the vaginal atrophy. So about 40% of these women, estrogen can definitely be a great and effective way to build up that vaginal wall again and get that health and the lubrication and the some of the pain away and that type of thing. And you can see some other ones here. Long-term estrogens do have help with cognitive support and cardiovascular support, as you can see in these depictions here about the different long-term effects of estrogens. So I love this chart because on the left here you see some of the symptoms and related conditions that go with estrogen deficiency. And then on the right side of the chart, what you can see in a patient who may have excess estrogen or your estrogen dominant females who aren't getting that balance with progesterone. So if you're seeing a lot of heavy bleeding, irritability, irregular bleeding, clots, endometriosis type things, you may want to think this patient has a lot of estrogen. They're probably estrogen dominant. Maybe there's some sort of progesterone answer that we can give this patient and help balance out their estrogen a little bit. So just thinking in terms, from a 30,000-foot level. If you think about some of the side effects of estrogen, I like to tell patients it's the 5 Bs. I typically get the question, what are the side effects of estrogen, or like what can happen to me if I take too much? And I say, just think about the 5 Bs. If you know you have one of these Bs, then you may be getting too much estrogen. You need to back off or talk to your doctor about getting a lower prescription or maybe a progesterone prescription to kind of balance that out. But the 5 Bs being breast tenderness, bleeding, bloating, brattiness, and breakout. So breast tenderness and bleeding, self-explanatory. Bloating, you could see fluid retention with too much estrogen. Brattiness, so if you think of crying, mood swings, that can be a sign of too much estrogen. And then breakout, so on the skin in terms of acne, so skin issues. This could mean estrogen dominance. This could mean just getting too much estrogen in their hormone replacement therapy, or maybe they're just very sensitive to estrogen and need progesterone. These are 2 significant studies that have to do with, 5 significant studies, 2 at the top I've kind of parlayed out for you, but 2 significant studies that just increased our knowledge of the estrogens and what they were doing inside of the body. You can see on the KEEPS trial, it relieved many symptoms of menopause, improved mood, bone density, and several markers of cardiovascular risk. In the ELITE trial, they did an early and late intervention trial with estradiol. And over 6 years, the women who were randomized to the estradiol, if in early menopause, had slower progression of atherosclerosis than the women that were randomized to placebo. However, the older women did not show those differences. So you can just see they tested it in several different realms, this particular one being atherosclerosis. Some of the other significant studies were Chronos, HERS, and the WHI, which we've kind of talked a little bit about. Here's your estrogen dosing. I'm not going to go over it in deep detail, but for perimenopause, you want to look at cycling your estrogens, because we're always trying to mimic what the patient's normal cycle is, right? So typically cycling this on days 1 through 25, if you think of the menopausal cycle in that chart that shows what hormones are high during that time of the month, with day 1 being the start of your period and around day 14 being ovulation, you're looking at the different hormones in the luteal phase versus the follicular phase and which ones are high and low. And so trying to mimic that by giving the estrogens cyclically during perimenopause. However, in menopause, natural postmenopausal or surgical menopause, continuous estrogens being the way to go there. Let's see, moving along, here's just some more description of the why there's different ratios. There's an 80-20 ratio and a 50-50. Estriol and estradiol are typically given together. The reason being they both target alpha and beta receptors all over the body. So there's even alpha and beta receptors in the colon, eyes, heart, on the skin, obviously in the vagina. So targeting both of those receptors with both of the estrogens is quite beneficial. However, sometimes, there's certain instances where we will just use estradiol alone or estriol alone, depending on the patient and what's going on, or if it's a vaginal prep or something like that. Progesterone is the next hormone that we'll talk a little bit about. It's commonly prescribed to counteract estrogen dominance. Now, progesterone is not progestin. If you see progestin, they're talking about a synthetic progesterone. If you see progesterone, they're actually talking about the bioidentical one. There is a trial called the PEPI trial. They studied women on progestin as well as natural progesterone and found that natural progesterone maintained all the benefits of estrogen on the cholesterol without any of the side effects associated with the synthetic progestin. So synthetic progestin showing many other side effects that the natural progesterone did not. So very interesting study. The PEPI trial was a monumental study for progesterone. And progesterone, interestingly, also has different metabolism when it's given topically versus orally. So when it's given topically, it does not go through the liver, does not get metabolized. It goes directly into the bloodstream and goes into effect. Versus oral progesterone actually does go through the liver, first pass metabolism. There is a metabolite that breaks off that connects onto the GABA receptor. And if you think about the GABA receptor, very down-regulating receptor, very calming, same receptor that houses the benzodiazepines if you think about anti-anxiety medications. That metabolite binds to GABA and actually gives a very calming effect. So a lot of the times if women are having trouble sleeping or anxiety type issues, an oral progesterone would be the preferred route because of that particular metabolism and helping those women in that aspect. You can read through these, but some of the intrinsic effects of that progesterone has on the body versus some of the reproductive effects. Same chart as we showed with the estrogens, but on the left side here you see some of the symptoms you may identify in a progesterone deficiency. And then on the right side with excess progesterone may see this in a patient. And typically with excess progesterone, that's only when you're overdosing a patient. A patient doesn't typically have too much progesterone. Females are naturally estrogen dominant, some more so than others. So for progesterone to be seeing these symptoms in a patient, if you do think they have an excess progesterone or a progesterone imbalance on the high side, or their labs are showing that as well, it could be because of your dosing or the previous dosing that the patient was receiving. So interesting about progesterone dosing, and we'll go over a little bit on the next slide, but oral dosing is always going to be about 4 to 5 times higher than topical dosing. So if you think of what's commercially available in progesterone, there's a 100 and 200 milligram capsule, correct? So when you're thinking about topical dosing, you want to divide that number by 4 or 5 in that range somewhere for a topical dose. Same thing with perimenopause, as we saw in the estrogens. Dosing is more cyclical in perimenopause, you're trying to mimic that cycle on days 14 through 25 is typically when you see the progesterone increases in a normal woman. And then in menopause, you can give it daily. It is continuous. Progesterone can be given alone or in combination with estrogen and testosterone. We talked a little bit about the oral way being best for patients who are experiencing some sort of overnight symptoms or overnight issues. And then it is always recommended to use progesterone with an estrogen. So if you're giving an estrogen topically, it is always recommended to give a progesterone with that. The only caveat really is vaginal estrogens don't typically need a progesterone because they are more of a local effect. They're at the vaginal mucosa or the vulva or vestibule. The dosing here a little bit more. We also use progesterone for infertility, PMS, and headaches. So we have dosing for that as well if you're interested in progesterone for those particular conditions. Let us know. We have different creams and oral dosage forms as well as vaginal dosage forms. Infertility doses are typically a lot higher, given several times a day versus just for menopausal therapy. So testosterone is another hormone typically in women that needs to be replaced. It does not, you don't see testosterone on that menstrual cycle chart. So it doesn't wax and wane as much with the menstrual cycle versus you're born with or you produce a certain amount of testosterone in your life that tapers over time. So just like in men, when we talk about hypogonadism, a man, usually at puberty, so 16 through 18, 20 years of age, testosterone is very, very high in men, and then over their lifetime slowly tapers off. Can taper at different levels depending on what's going on in their life, exercise or testicular atrophy, that kind of thing. But in women, it's sort of the same thing, just a slow down slope. And this can lead to a lot of low libido type issues, low energy type issues, losing muscle mass, that type of thing. So we definitely use this as a replacement or a restoration therapy as well. 50% of women in natural menopause will lose their testosterone or not produce it as much. And then 80 to 90% of women in surgical menopause will lose testosterone. So definitely something to be considering, especially if your patient is complaining of fatigue, libido, energy issues. All the potential benefits of the androgens help alleviate things such as hot flashes. There are still testosterone receptors all over the body, so very important hormone to remember in women as well. We think men, but also women. Another chart you can take a glance at for your patients who you may think have a testosterone imbalance. Excess testosterone is very interesting. It can actually cause facial hair, acne, oily skin, nipple pain, that type of thing. I've also seen aggression in women, or even like over anxious about things, and it means the testosterone was overdosed a little bit for their particular body. So maybe they are, slower metabolizers, and the testosterone's hanging around longer in their body. Whatever the case may be, these particular patients may show up with these symptoms. The dosing here, typical dosing for a woman is about 0.5 milligrams to 5 milligrams a day. In men, you see very much larger doses, 50 milligrams, 100 milligrams, 200 milligrams a day. You can imagine men need more testosterone than women, but women still do need that. It is prevalent in their bodies as well. Testosterone can give a little energy boost, so we always counsel as a pharmacist to apply it in the mornings. I've had a patient laying awake at night. She said her eyes were wide open for hours, and I asked her when she was applying her testosterone, and she said at night. So I was like, try the morning. You might see a benefit of having a little bit more energy throughout the day and then able to sleep easier at night. And the testosterone dosing is here. We kind of talked about that earlier. Testosterone also very good for vaginal use in terms of lubrication, libido, clitoral stimulation. I won't go so much into the DHEA and pregnenolone. You can read about them here, but they're really, we call them precursors to the androgens. The body really pulls DHEA and pregnenolone. If you think about that steroid hormone cascade that I showed you at the very beginning of the presentation, if you think about that particular cascade, you can try to visualize the body wherever it's lacking. So if it's lacking the estrogen, testosterone, progesterone, something like that, it's actually going to pull DHEA and pregnenolone down a particular pathway that it needs to. So we call these precursors or grandfather hormones. Just the body is miraculous in that it kind of uses them where they're needed the most. And these are for men and women. So you can see some of the benefits of DHEA here. Dosing, typical dosing for DHEA, it can be given orally, it can be given vaginally, it can be given topically as well. Pregnenolone, same thing we were talking about with DHEA. And sometimes in times of higher stress, when the demand for cortisol rises, you may get what's called pregnenolone steal. And those patients who are desperate for cortisol, they're going through times of stress, the adrenals overworking, it's pulling pregnenolone out, which is causing a deficiency downstream in the hormone sector, the hormone imbalance. So going back to that hormone cascade, just seeing where the different hormones are upstream. So pregnenolone steal is real, sometimes causing a hormone imbalance. So step one would be to get the adrenals corrected, get the patient on some sort of supplements, adaptogens, lifestyle changes in order to get their hormones back in balance. And then if needed, also restoring some of the hormones that are out of balance. So a couple more functions of pregnenolone here. Pregnenolone DHEA in men is really wonderful for mental health, so mood, memory, those type of things. We see a lot of patients on pregnenolone DHEA combinations for mental health. And then you can see the dosing here. A little bit on lab testing. We typically get the question, what labs do I run for these patients? Depending on if it's male or female, obviously, but I always recommend a full thyroid panel. We want to make sure the thyroid is good. That's always the first thing that you need to correct. So if you have a thyroid imbalance, that is most important, because correcting the thyroid in turn sometimes corrects the hormone imbalance. And then also, if you treat the hormone levels first, like the female sex hormones or the male sex hormones first, and then you find the thyroid issue, you have to go back and adjust your hormone replacement therapy, because your thyroid, once it is corrected, actually can help a lot of those sex hormones get back into their groove. So fixing the thyroid first is always important. I like to recommend, the lab companies now have a lot of nice panels that you can get, so like a female hormone panel, male hormone panel, but always getting an all-encompassing look. And at Innovation, we can also help you interpret those labs. So if you send us your patient labs and patient history, we can help you come up with a plan of action or some recommendations for them if they qualify for hormone replacement therapy or if not. And here I just went over a little bit about saliva versus serum testing, depending on, there's kind of a controversy out there which one's better than the other. We are all definitely used to serum testing. It is the more cost-effective option, insurance coverage, that type of thing. It definitely gives a snapshot of the hormone levels or what the overall arching issue may be. Saliva testing is good if you're on some sort of topical hormone replacement therapy. It measures more of the capillary blood, so giving you a more accurate description of what hormone levels currently are. This is by far my favorite chart. This chart is also included in our clinician's guide, which you can get a copy of. If you would like to contact us, we can send this to you. But this is such a great chart because the patient comes to you and is complaining of certain symptoms. You can check out this chart and see what it actually may be caused by. So if they come to you, oh, I'm having terrible cramping, it could mean that they have low progesterone levels or something like that. And this isn't all encompassing. We all know that there's definitely more factors that go into it than a simple chart. We know no patient can be put into this box or into this chart and it be the miracle cure for them. So this is just something to kind of, I use this as a justification. So I'm looking at labs, I'm hearing all of their symptoms, I'm getting their history, figuring out, a whole picture of what's going on in the patient. And I'm thinking in my head, oh, I think they may need progesterone and testosterone in some certain amounts. And then I'll go to this chart and kind of justify, okay, yeah, these are the symptoms they're having. Okay, yeah, this is what it looks like we're going to have to replace. So great chart. Feel free to take a picture, or we can give you a copy of this as well. This is just a small glance at female sexual dysfunction and pelvic pain. I don't know if you guys see a lot of these patients, but definitely goes hand in hand sometimes with the hormone replacement therapy patients. There are certain female sexual health issues and conditions that have to be treated. And compounded medications really play a big part in that, because a lot of these drugs aren't available commercially or in certain combinations to where would be beneficial for the patient. So if you do see these particular patient populations, feel free to let us know. We have an entire line on female sexual dysfunction and pelvic health, interstitial cystitis patients as well. So let us know and we can get that information over to you. We do have clinical materials that are available to you as a provider. Those are free of charge. You just have to contact us and we can get those sent out to you. And they're just clinical summaries and summaries of evidence, and then our prescription templates as well to kind of help justify some of the therapies that we're recommending, and then just give you an overview. So that's all I have today. Thank you guys for bearing with me. I know it was long. There was a lot of information there, but to get it all into less than an hour is definitely a big task. This is something that I try to teach over a couple days span to providers and students. So to get it in an hour is definitely an accomplishment. So anyways, you guys, thank you so much for listening in today. If you have any questions whatsoever, I have my email down there at the bottom, Thompson, and at innovationcompounding.com. And then there is our phone number. And if you need any more clinical materials, just give us a call. We have 8 pharmacists on staff who are more than happy to help you, and such knowledgeable people in terms of hormone replacement therapy, hormone restoration therapy, men's health, and women's health when it comes to hormones. So thank you guys so much for today. Feel free to reach out if you have any questions, and take care.